Hi, everyone. Welcome to the SEEDS webinar for tonight. Thank you for attending. Today, we're very privileged to have Prof. Fang from Shanghai to give us a talk on thymic malignancies. He's a world authority. If you check out all those published literatures on thymic malignancies, there's no doubt you'll find his name. He's a world expert on thymic pathologies. And we are very, very privileged to have him here with us tonight. So we will first of all listen to his lecture, then Anise will join in to have a discussion with Prof. Fang about some of the issues surrounding thymic malignancies. Then I'll be moderating the sessions with your questions that you would like to pose to the two speakers for tonight. So Prof. Fang, if you want to take us away.
Thank you, Sun, for your kind introduction. And thank you, Anise, for the kind invitation. First, what's so special about thymic epithelial tumors? Because some of you might think there are some thymic tumors that are benign and some are malignant. But actually now all thymic tumors are considered malignant because even stage 1 tumors may recur after complete resection. And those type A thymomas, which used to be considered benign, actually were found to have can have a metastasis after surgery. So we call them a typical type A. So nowadays, all thymic tumors are malignant. So, but thymic tumors are relatively rare. According to the results from the SEER database, it's estimated that the incidence is around less than 3 per million. And most of the tumors are quite indolent in nature because most of the recurrence are in the form of a local regional recur. And patients are expected to have a long-term survival even after a recurrence. So because of the low incidence and the relative indolent nature of the disease, there's very low level evidence considering how to manage these tumors. And actually, many of the diagnosis and treatment strategies are highly controversial. We have been using the Masaoka-Koga staging system for more than 30 years. It's not until the 2014 when ITMIG and the UICC published the first international TNM staging system for this tumor based on the large retrospective database. And there's some consensus regarding the histology of this tumor when the ITMIG had published the third WHO histological classification for this tumor in 2015. And if you look at the guidelines, most of the suggestions and recommendations are actually based on experts' consensus, which is a level 2B evidence. So when we are making therapeutic decisions for malignant tumors, we usually base on prognostic factors of the disease. For thymic tumors, the 3 most important prognostic factors are actually tumor stage, histology, and resection status. According to the results from the Chinese Alliance for Research in Thymoma national database, we found that the 10-year overall survival after resection for thymic tumors could be as high as 76%. And you can see how the prognosis of patients could be stratified beautifully according to the tumor stage, according to the WHO histology. If you divided the tumors into type A, AB, and B1, which are considered of low risk, and type B2 and B3, which are intermediate risk group, and also thymic carcinoma and the neuroendocrine tumors, which are considered of high risk in recurrence. And for those tumors which could be completely resected, the survival was actually very good. But for those tumors that cannot be completely removed, the prognosis of the patient would be rather dismal with a 10-year survival of 45%. So how do we manage thymic epithelial tumors? We used to adopt a strategy of resection, taking it out, whatever. and then maybe add radiation after surgery. But is that the right approach? I don't think so. So what are we talking about when we talk about surgical management of lung cancers? We talk about whether surgery is rather is indeed in need for a patient with a small nodule. We talk about resection extent, whether it's a lobectomy or sublobar resection for early stage diseases. We talk about surgical approach, whether it should be minimally invasive or open procedure. We talk about lymph nodes, whether dissection or sampling is necessary. And after surgery, whether the patient should receive adjuvant chemotherapy or radiation, or just a follow-up. In fact, for thymic epithelial tumors, we talk about the same things: surgical indication, resection extent, surgical approach, lymph node dissection, and post-operative management. So for the first question, whether surgery is indeed in need or not, this is a very interesting paper published from the Mass General Hospital from Harvard Medical University. Actually, they looked at 160 mediastinal procedures and found that in 70 cases, the surgery was actually not necessary. That means 43.8% of the patients had a non-therapeutic surgery. These include 23% lymphomas and 8% germ cell tumors, which should have been treated with chemotherapy and radiation. And there are 11% of cystic lesions, 8% of hyperplasia, and 2% of reactive diseases, which should not be resected at all. So when you what you used to know about the constitutions of anterior mediastinal lesions, most of the literature were from surgical databases. And this was a real-world study by the ITMIG, International Thymic Malignancy Interest Group. Together with Anya Rodden from the Mayo Clinic, we've used a global imaging database to look at what's the real incidence of different lesions located in the anterior mediastinum. And we found that among more than 3,000 cases of CT imaging, thymic epithelial tumors ranked the #1, which accounted for 28% of all anterior mediastinal lesions, but there are also 20% of cystic lesions and also 16% of lymphomas. And this was the data from the worldwide database. But if you look at the Asian database, which comes from the Shanghai Cheif Hospital, we found that 35% actually of the lesions were actually cystic lesions, which should not be considered malignant. And there were only 30% lesions, which turned out to be thymic epithelial tumors. So the incidence of the thymic epithelial tumors used to be considered quite low, which, as I told you, was 3 per million from the SEER database. But actually, with the increasing use of the CT screening for lung cancers, we found an increased detection of thymic epithelial tumors. If you look at the screening trials for lung cancers, the LCAP from the United States, Cosmos study from Europe, and there's also a lung cancer screening trial from Seoul National University. And also, if you look at the Framingham study, which is a surveillance trial for cardiac diseases, we found that the incidence of thymic epithelial tumors was actually around 30%, 0.3%, which is almost 100 times higher than what is derived from the SEER database. And in China, we also see a rapid increase in the detection of small anterior mediastinal lesions because of the CT screening for lung cancers. This has led to increased surgery at the Shanghai Cheif in the past 10 years. And how to manage small anterior mediastinal nodules, which are incidentally detected. So the American College of Radiology published a white paper on incidentally detected asymptomatic mediastinal mass almost 2 years ago. And they suggested that for anterior mediastinal nodules, The first thing is to differentiate whether it's a cystic lesion or a solid lesion. And if it's a solid lesion, it's recommended that we should look at the edge and contour of the lesion to decide whether it's an invasive lesion or not. And at the Shanghai Chest, we basically followed a similar approach. We would use the serum tumor markers and CT scan to make the first differential diagnosis. If the serum tumor markers suggest that the lesion might be a germ cell tumor or a lymphoma, this patient should be managed by our medical oncologists with non-surgical therapies. But if it's suspected to be a thymic tumor, we would look at the CT scan and decide whether the lesion is well demarcated or not, whether there's a lobulation of the lesion, and this would help differentiate from benign to malignant lesions. But most important thing is we want to avoid non-therapeutic procedures. So we found that MRI is extremely helpful in differentiation of cystic lesions. If you look at the CT scan of this lesion, it clearly looks like a cystic lesion. And on MRI T2 series, you can see it has a long signal and enhanced MRI. There's no attenuation of the lesion. So this is a typical thymic cyst. But again, this lesion looks like a cyst on CT scan. But if you look at the MRI, you can see, although it also has a long signal on T2 series, the lesion has a quite thickened wall around the cyst. And then on enhanced MRI, you can see the wall of the lesion has a quite marked high attenuation, and this is suggestive of a cystic thymoma, and the lesion was resected by surgery and turned out to be a thymoma. So in the past 6 years, we followed 101 patients with small anterior mediastinal lesions, less than 3 centimeters in size. And the 91 patients actually received upfront surgery after imaging diagnosis, and 84 of them turned out to have thymic epithelial tumors, with only 5 cystic lesions misdiagnosed. So the rate of the non-therapeutic surgery based on CT and MRI differentiation was merely 5.5%. And the rest, 328 patients, were considered to have thymic cysts, which accounted for almost 2/3 of all patients in this group. And the rest of them were considered either being lymph nodes or hyperplasia or thymic, suspected to have thymic epithelial tumors, but the patient refused to have surgery because of the fear of risk associated with the procedure. So we followed these 328 patients, and none of them received the surgery, and there was no adverse events observed in this group. Most of the lesions remained stable after median follow-up of 6 to 7 years, 6 months to 7 years. And you can see there were only 3 lesions increase in size, but there are also 2 cystic lesions decrease in size. There are 2 patients with suspected of having the thymic hyperplasia actually decrease in size. For 13 patients suspected of having the thymic epithelial tumors, only 2 of them increased in size after 2 years of follow-up. The increase in size was only 2 to 3 millimeters. So we, among the 84 patients who were thymic epithelial tumor patients surgery, actually 38 of them had more than 1 CT scan before surgery. And we calculated tumor doubling time for these patients. We found that for low-risk patients, which consisted of type A to B1 tumors, the tumor doubling time was very long, around 2 years. And for intermediate risk patients, that's B2 and B3 thymomas, and also thymic carcinoma and neuroendocrine tumors, the tumor doubling time was significantly shorter than the low-risk tumors. However, it was still as long as around 9 to 11 months. So according to our experience, as well as based on the recommendations from the American College of Radiology, we found that because of the increased use of CT screening of lung cancers, the incidence of thymic tumors were actually much higher than we used to consider. However, we should still try to avoid non-therapeutic surgeries, and differential diagnosis with imaging and tumor markers is very important in achieving that. For incidentally detected small nodules, most of them, actually more than 2/3 of them, are benign cystic lesions, with only less than 20% of them being thymic tumors. And MRI is extremely helpful in therapeutic decision-making. And also there's a very wide time window for intervention. There's no hurry for upfront surgery. So the second question would be, if we decided to go to surgery for an early stage tumor, whether we should do a thymectomy or a Thymomectomy, that is resection of the tumor only. The traditional teaching would be to do a thymectomy for all thymic tumors, because the incision is already there with the sternotomy, and the trauma is already there. And in adults, the thymus has no function, so it's okay to remove it. And there's if you're doing a partial thymectomy, there's an increased risk of tumor recurrence if the tumor cannot be completely removed. And also there's the risk of the novel myasthenia gravis. But that means myasthenia gravis developed after surgery. And in case of recurrence, it is very difficult and risky to do a reduced sternotomy. However, in reality, we found an increased use of Thymomectomy around the world, because there's no guideline on resection extent. And because of the early detection of small lesions due to the CT screening for lung cancers, and many surgeons think just to remove the tumor is all right. And also because the introduction of minimally invasive surgery, where people would tend to do a lesser surgery with this minimally invasive approach. So, but there are problems with this idea of Thymomectomy. One of the typical cases I would like to show you is this patient who was detected of having a small lesion in the anterior mid-thymum, which measured only 1.5 centimeter. And she received the surgery at another hospital with a surgeon removing only part of the thymus with a nodule. And upon histological examination, it turned out to be a fatty tissue, which was diagnosed as a lipoma. But 6 months after surgery, we did a repeated CT scan, and the lesion was still there. So, and we did an MRI on this patient, and the result turned out to be quite different. We suspected it's a thymomas or thymic tumor. So we went in there again at the Shanghai Trust and removed the thymus completely and found a almost 2 centimeter lesion there, which turned out to be a thymic carcinoma. So if you're going to just remove the lesion, a small lesion, probably just remove the wrong lesion with the real one hidden in the thymus. And also there's the possibility of multiple lesions with thymic tumors. And even with early stage tumors, it's really difficult to identify whether the tumor has transcapsular invasion by naked eye. And there's a risk of inadvertent capsule violation during surgery if you're just trying to remove the tumor itself. So we did a retrospective multi-center database analysis using the ITMIG global database. And we found that upon multivariate analysis, we found that the predictive factors for total thymectomy were geographic regions, where in Asia, surgeons are more likely to do a partial thymectomy well, in Europe and North America, surgeons usually prefer total thymectomy. And it's also related to surgical approach. In case of a stenotomy, most surgeons would do a total thymectomy, but in case of lateral thoracotomy and minimally invasive surgery, which are usually from a lateral approach, a partial thymectomy is more preferable. And for large tumors, for smaller tumors, a partial thymectomy is often used. So if you look at these two figures, you can see how minimally invasive approach has been increasing in the past years and how partial thymectomy were mostly used by Asian surgeons. So we also look at the oncological results from this analysis. We found that although the overall survival was similar between partial thymectomy and total thymectomy groups, we found that the incidence of cumulative incidence of recurrence will actually tend to be higher after partial thymectomy at 10 years than after total thymectomy, although the p-value did not reach a statistical significance, but you can see how the end raised up with partial thymectomy. And we did a similar retrospective study using the chart database, but this time we used patients with clinical stage 1 and 2 disease because we found it's difficult to decide whether the lesion was in stage 1 or 2 before surgery. And although the recurrence rates between total and partial thymectomy was similar in stage 1 disease, you can see how it raised in after partial thymectomy comparing to total thymectomy in stage 2 diseases with a statistical significant difference. So regarding the resection extent, the current recommendation should still be total thymectomy for all thymic epithelial tumors so that to make sure that radical resection of the lesion and accurate station of the disease could be achieved. So unblocked resection together with the thymus should be recommended, and at least one should avoid enucleation of the lesion. At least you should try to remove enough normal tissues surrounding the lesion. So the third question would be whether for early stage tumors, are we going to do an open or minimally invasive approach? So according to the guideline, minimally invasive thymectomy is still not recommended routinely because of lack of long-term data. However, if we want to prove that minimally invasive surgery could be used for early stage thymic tumors, we need to prove that the perioperative results after minimally invasive surgery should be better than open surgery. And more importantly, we need to show that the oncological results after minimally invasive surgery should be at least not inferior to open surgery because we are treating a malignant tumor. So to look at by oncological results, we would look at complete resection rates, which is the most important prognosis factor for thymic tumors. Of course, we would look at survival of the patients, but more importantly, because patients could have a long-term survival even after recurrence, it is more important to look at recurrence data to see whether it's indeed oncologically equivalent. So in the real world, although minimally invasive approach is still not recommended by guidelines, we saw a rapid increase in the use of minimally invasive surgery for thymic tumors in the ITMIG global database, in the Japanese Association for Research in Thymic Tumors database, in the Chinese Alliance for Research in Thymoma database, and also at the Shanghai Cheif Hospital, where most of the early stage lesions are nowadays resected by minimally invasive surgery. So what's the advantage of minimally invasive surgery? I think it's basically self-explanatory because by avoiding the sternum split, by avoiding the rib spread, by not cutting through the muscles, I think your patient would choose, by looking at these two pictures, your patient would choose with their feet. But there has there have already been mountains of evidence showing that comparing to open stenotomy, minimally invasive thymectomy has the advantage of at least a similar or shorter operation time, diminished pain, less affected pulmonary functions after surgery, and less complications after surgery, together with a shorter length of hospital stay and better quality of life of the patients. To name a few studies, these were the results from the Shanghai chest. We found a decreased blood loss, shortened chest tube drainage, less transfusion, length of hospital stay, and shorter intensive care stay and hospital stay after minimally invasive surgery. And my friend Jens Ruckert from Berlin also showed the benefits of minimally invasive thymectomy in patients, to their patients with less usage of painkillers, and also the better recovery of pulmonary functions after minimally invasive thymectomy comparing to mediastinotomy. However, what's more important is the oncological results. So the first thing is, can we achieve a similarly R0 complete resection rate to open surgery? So the first study was the ITMIG global retrospective database analysis. We did a propensity score match analysis comparing 266 pairs of patients receiving either minimally invasive or open surgery. All these patients had thymomas. And we found in selected patients after propensity score matching, complete resection rate was similar between the two groups, which was very high, 60% in both groups. And also we did a multivariate analysis for the prognosis factors, predictive factors for complete resection. We found that in Europe, the complete resection rate was much higher, and with the time and also the increase of tumor stage, the resection rate could be completely different. And again, we found total thymectomy is helpful for a complete resection of the tumor, but surgical approach is not a predictive factor for complete resection. So this means that if you observe the oncological principles during surgery, you can do a safe, minimally invasive surgery and remove the tumor completely. And this was another recent evidence from the Japanese Association of Research in Thymoma retrospective analysis. They compared 140 pairs of Masaoka stage 1 and 2 thymomas, which are considered early stage lesions. And they found only 3 cases of R1 resection and 1 case of R1 resection in minimally invasive and open groups, respectively. And the 5-year OS and the IFS in both groups were comparable. And you can see how these two survival curves, the overall survival curves and the recurrence-free survival curves, overlaps with each other. And similarly, we used the Chinese Alliance for Research in Thymoma retrospective database and did a propensity score match study in 110 pairs of UICT stage 1 tumors, which would be equivalent to Masaoka stage 1 and 2 tumors. But what's different that's included in this study were also thymic carcinoma patients in addition to thymoma patients. And because all lesions were in stage 1, we found that the resection rate, complete resection rate was 100% in both groups. And again, the 10-year overall survival and incidence of recurrence were comparable between the two groups. And we also did a multivariate analysis for overall survival as well as for the risk of recurrence. Because all lesions are in stage 1 and all patients had a complete resection, so the only risk factor left over was WHO histology of the tumors, with type B tumors significantly worse than type A and AB tumors with thymic carcinoma, and the neuroendocrine tumors had worse survival. But neither did we found that surgical approach was a predictive factor for overall survival or recurrence of the disease. So now we have more evidence to say that for UICC stage 1 or Masaoka stage 1 and 2 thymic tumors, there's a trend toward increased use of minimally invasive approaches around the world. And better peri-operative outcomes could be achieved with minimally invasive surgery. And also, more importantly, we observed a similar oncological results in terms of complete resection, overall survival, as well as incidence of recurrence, as long as oncological principles could be observed during surgery. And the surgical approach is thus not associated with a worse outcome. So the fourth question would be whether we need to do a lymph node dissection or not. The traditional teaching is that lymph node dissection is not necessary for thymic tumors because of low incidence of lymphatic involvement in these tumors, and because it is unclear whether lymph node status is associated with prognosis of the patients. Therefore, the current guidelines does not recommend routine lymph node dissection. However, if you look at the Jiaotong retrospective study, you can find although the incidence of lymph node metastasis was only 6% overall for tumors with local invasion, and especially those thymic carcinoma and the neuroendocrine tumors, the incidence could be of lymph node metastasis could be as high as over 10 to 30%. And in thymic carcinoma, lymph node metastasis was found to be associated with patient's prognosis. And my friend Benny Wexler did 2 interesting studies using the SEER database. First, he looked at 400 patients of with thymomas who had at least 1 lymph node removed during surgery. And he found that the rate of lymph node involvement could be as high as 13% and increase with the extent of the invasion of the tumor. And also patient prognosis was associated with the status of the lymph nodes. And then he did another study using the same database, looking at 176 thymic carcinoma and 53 neuroendocrine tumor patients who had at least 3 lymph nodes harvested in this study. Surprisingly, he found that the lymph node involvement rate could be as high as 40%, which was the highest in neuroendocrine tumors, over 60%. And again, worse survival was associated with lymph node metastasis. So we used the Chinese retrospective database and also did a similar analysis in 2,400 patients. We found the overall incidence of lymph node involvement was rather low without lymph node dissection. But still, we found that lymph node status was associated with 5-year overall survival, as well as with a 5-year cumulative incidence of recurrence. And based on these results, we did a prospective study on intentional lymph node dissection. With help contribution from 15 hospitals in China, we were able to accrue 275 patients in 1 year and a half time. The complete resection rate was very high in this group, and an average of 5 lymph nodes, 3 stations of lymph nodes were removed in this group, and we found a 5.5% nodal involvement rate in this series. And we did an interesting comparison between the results of Chart's retrospective database and the Chart's prospective analysis, and we found that the rate of lymph nodes involvement increased with tumor histological grade, as well as the extent of invasion of the primary lesion. And comparing to non-intentional lymph node dissection with the intentional lymph node harvesting, the rate of nodal metastasis was much higher than found in the retrospective study, which could be very high in thymic carcinoma and neuroendocrine tumors. And the result was similar to those found by Benny Wexler, and also in T3 and T4 lesions. So we built a risk model for lymph node metastasis in thymic tumors, and we found that intentional lymph node harvesting may significantly increase the rate of nodal yield. This would help increase the staging accuracy as well as the radicality of surgery. So for lymph nodes issues, we think that overall lymph node metastasis is relatively rare in thymic tumors, but it's still associated with prognosis of patients, and it's not uncommon in a high-risk group, especially in higher T stage and higher grade tumors. So selective lymph node harvesting should be recommended in this high-risk group of patients. So after surgery, should we do adjuvant therapy, or how should we follow up our patients? This is the NCCN guideline for postoperative management. As I told you before, these were recommendations based on consensus of experts, but what's the evidence from clinical studies? This was a retrospective study by the Chinese Alliance of Research in Thymomas. We stratified our patients according to the risk of recurrence after complete resection, and we found that all T1 thymomas and those low-risk thymomas with local invasions, they could be classified as a low-risk group, while all thymic carcinoma, neuroendocrine tumors, and those intermediate histology thymomas, that means B2 and B3 thymomas, which had already had local invasions, should be considered a high risk in developing recurrence. And the recurrence rate you can see could be significantly different from these two groups, with a marked difference in 10-year recurrence-free survival in these two groups. And we also look at the pattern of recurrence in the low risk and high risk group. For the low risk group, only 11 of the patients had distant metastasis, and all the recurrence were distributed evenly throughout 10 years after surgery. But for the high risk group, it's a completely different scenario. Distant metastasis accounted for almost 2/3 of all recurrences, and most of the recurrences were found within the first 3 years of this after surgery, with almost all recurrences detected within 6 years after surgery. So we, based on these findings, we made a recommendation that for low risk group, maybe any CT scan would be more than enough for follow-up. And the follow-up should last for 10 years after surgery. But for high risk group, the patient should receive the full examination for 6 years. In the first 3 years, it should be repeated every 6 months, and then annually in the later 3 years. So as to adjuvant therapies, actually there's no consensus whether radiation or chemotherapy is necessary or helpful for our patients after complete resection. So post-operative radiation has been recommended for high-risk patients. However, according to chart analysis, there's no survival benefit seen after complete resection, and post-ports only help decrease recurrence after incomplete resection. And there are a lot of similar studies supporting this, having the same observations. And for post-operative chemotherapy, although it's been recommended for stage 4 in the thymic carcinoma or those who had incomplete tumor resections, we did another propensity score matched analysis, and we found no survival benefit whether the patient received chemotherapy or not. So basically, at this moment, complete resection is still the most important prognosis factor for surgical management of thymic tumors. And the follow-up strategy should be stratified according to the risk of recurrence. And the role of adjuvant therapy is still unknown, and it should be only recommended in high-risk groups. And whether its benefits in prolonging the survival of the patients or decreasing the recurrence should still be investigated in the future. So what are we talking about when we talk about surgery for thymic tumors? So we talk about whether a small lesion should receive surgery or not. We talk about the surgical approach and the resection extent for early-stage tumors and how they should be managed after surgery. And for local advanced disease, whether harvest of lymph node is necessary and whether adjuvant therapy would be helpful. So the current evidence would suggest that the incidence of thymic tumors are actually more common and should raise enough attention for surgeons around the world. And at the same time, non-therapeutic surgery should be definitely avoided to the best extent. And to make a therapeutic decision-making, it should be based on the 3 major prognosis factors: the tumor stage, histology, and resection status. How to define successful thymic surgery? It should be a safe surgery in the first place, and it should be make sure that tumor is completely removed. This is for the best, provide the best chance of cure for the patient, and also would provide the accurate stage of the tumor. And the current recommendations for surgical approach and procedure would be a minimally invasive surgery could be tried in early stage lesions, but still total thymectomy should be recommended. And in high-risk patients, lymph nodes dissection should be recommended for complete resection and accurate staging. After surgery, the patient should be followed up according to the risk of recurrence, and the role of adjuvant therapy should be studied more in the future. So for rare disease, I believe that more efforts should be gathered from around the world. If we could work on this together, we can have a better evidence how to better deal with the disease. I think this is a collaborated efforts is definitely very important for better understanding of this disease. Thank you so much for your attendance.
Thank you, Professor Fang. Wonderful presentation as usual. I think I hear claps in the background. So to all your listeners out there, good evening and warm welcome to our SEEDS channel. So me and Prof. Fang have designed a kind of a fireside chat and a Q&A session for you all, which most of it, half of it he's covered in his talk already, but we will go through them, but we'll go through in a Q&A fashion so that it gets to your curiosity. We have a set of 10 questions. We'll start with the first one, Prof. Fang, which will be, does the new classification, does the WHO new classification really correlate better with clinical outcomes? That is the staging.
Yeah, I think so, because any staging system should be based on the prognosis of the patients under the current treatment. And the ITMIG UICC ISLEC staging system was the first one based on the large population of patients. If I remember it correctly, it was based on over 10,000 patients collected in the ITMIG retrospective global database. And if you know, I'm not sure if everyone knows that the Malaysia staging system was based on merely some 90 patients from single institutions treated more than 30 years ago. So I think the ITMIG staging system, I mean, the first TMN staging system is a much better one, more evidence supported. However, I won't say it's an ideal one, because we failed to stratify the patients beautifully in some of the descriptors, like in the M and N descriptors. The survival was not stratified very clearly. So currently we're working on a second edition, according to together with the SPFC of the ISLEC. We're working on a 9th staging system for this tumor. We have successfully collected more than 7,000 new cases from all the contributions around the world. I hope that with more cases, this time we could do a better job.
Right, so next question. So the next 2 questions are basically case discussions. So the first case is a 3-centimeter thymoma, which is well encapsulated, surgically removed. Histology comes back as a thymoma B2. Question number 1, what is your opinion on adjuvant radiation therapy for this case?
Okay, that's the question number 1. So what's question number 2?
Does the size influence your decision at all on adjuvant therapy? And the last question, does the type of thymoma between a B2 and a B3 influence your decision more than the size?
Well, you're right. These questions are actually relevant to each other. I think there have been a lot of studies on the role of port after surgery. As I told you during my talk, we found that port might be helpful for those tumors that had not been completely resected. But after complete resection, there have been enough evidence in literature showing that for Maselka stage 1 and 2 or UICC stage 1 tumors, after complete resection, there's no additional benefit of radiation, adjuvant radiation. There was a beautiful study from the Mass General Hospital some 20 years ago. And also this was a result from the European study, from the Jiaotong study, from the Chinese study. So I think it's not the tumor size or the histology that matters. It's whether the tumor could be resected completely.
Right, that's 3-in-1 answer. So I move to question number 3 now. So this is another case. It's a case of a 5-centimeter primary thymoma with a single pleural met on the pleura. So the questions are as follows. I think we'll take 2 at a time. There are 4 questions. What is your opinion on neoadjuvant treatment in these cases? 2, what is the type of surgery you would prefer? Just thymomectomy alone, thymomectomy with total clearance, versus local pleurectomy versus EPP?
Well, that's an interesting question. Well, according to the guidelines, the patient already had a stage 4 disease. So chemotherapy should be recommended as the first-line treatment. However, the response rate of chemotherapy for thymic tumors are actually quite low, especially in thymomas. For thymic carcinomas, the response rate would be somewhere around 20%, but for thymomas, it's less than 10%. So I don't think chemotherapy actually is helpful for stage 4A thymoma. So especially given the indolent nature of the disease, I think that removing the main lesions would be helpful in achieving a prolonged survival as well as a good quality of life in this patient. So usually we would try to remove the tumor completely together with the lesions in the pleura. But the ideal procedure for this scenario is quite controversial. You need to balance between the risk and benefits of different procedures. Of course, in terms of radical resection, I think that EPP would be the best one. But in the same time, it's a very extensive procedure with a very high morbidity rate, and it really makes the patient, devastating. It's a devastating procedure. It severely affects the quality of life and functional status of the patient. So nowadays, like just similar to surgery to mesotheliomas, I think the prognosis would be the better choice in trying in an attempt to remove the visible lesions. And there are some small series retrospective reports showing that hemithorax pleural irradiation might be helpful after prognosis in preventing the progression of the disease. So currently at the Shanghai Chest, we would do a prognosis and pleural irradiation after surgery. And I did try intraoperative thermal chemotherapy irrigation, in the past 3 or 4 years, and contrary to what was reported in literature, we found that it's not that effective. And the disease control rate was not that ideal as reported. So we have abandoned that strategy and now returned to prorectomy plus irradiation.
That was question 3, by the way. Would you use hyperthermia in your thing, which you've answered, and adjuvant radiation also you've elegantly answered.
Yeah.
I'm going to move on to the next question. For all your listeners out there, I'm just targeting Prof. Fang because he's just not only a surgeon, but he's also a surgeon with a lot of basic science and oncological knowledge in the field of thymic cancers. So the next question is, what do you think of your role of immunotherapy in the present day world of thymoma?
Well, that's a difficult question. Actually, immune therapy has received a lot of attention in the past few years. It has been, it appeared to be quite effective in the treatment of lung cancers and esophageal cancers. Those are also thoracic chest diseases. But for thymic tumors, there's been only 2 phase 2 trials trying immune checkpoint inhibitors in stage 4 thymic carcinomas. So currently in China, there are also 2 ongoing phase 2 trials studying the efficacy of immune checkpoint inhibitors on stage 4 thymic carcinomas. However, for thymomas, there has never been any, large number of cases studied in clinical trials. In the Korean trial, they actually studied the efficacy of, in a phase 2 trial published by the Korean group, they also included several thymoma patients. Yes, but one thing should be keep in mind that the most serious side effect would be immune-related adverse events associated with immune checkpoint inhibitors, and they actually found one such case in their study. So I think one should be very cautious in trying these kind of agents in thymoma patients, because thymoma is known to be associated with high incidence of autoimmune diseases.
Okay. Tricky question for you. Do you do PET-CT scans routinely for your thymoma? And if you are, how does it actually influence your decision making?
Oh, that's a good question. I don't think a PET scan is necessary for all thymic tumor patients, because as we touched in the talk, most tumors are quite indolent in nature, and only some high-risk group would have lymph node metastasis, and distant metastasis is quite rare in this disease. So the role of PET scan is mainly the role of PET scan is to detect nodal disease and distant organ involvement. So I don't think there's a role for PET scan in most of the thymic tumors. However, for those suspected of having thymic carcinoma or those with extensive disease, already on CT scan, I think PET scan is rather helpful. So at the Shanghai Chest, we would only order PET scan for such a high-risk group of patients.
I would agree with that completely. I think we nowadays tend too much to believe what we see on PET-CT scans, which are actually more of a confusing
than
helping us. Yeah. Is any stage of thymoma actually exempt from a surgical option? Or in what case would you say, okay, this patient is not for surgery, if the patient is fit?
Well, to go for surgery, usually we would look at the tumor stage as well as the patient's performance status to decide the risk and benefits, to balance the risk and benefits. Actually, the general principle is if the chance of the survival is higher than the risk of mortality of the procedure, we would think the procedure is worthwhile, right?
Yes.
So usually for most of the thymic tumor patients, we would try surgery at some point, like especially for those tumors that could be completely resected. But for those tumors already advanced disease, those with lymph node involvement, and those with dissemination in the pleura or the pericardium, of course we would try neoadjuvant therapies to some extent, but you can't say that it's always helpful, because there has been very little evidence on the efficacy of neoadjuvant therapies on this rare disease. The only literature on induction chemotherapies were published some 20 years ago. Most of them were from Italy. Actually, they reported very high response rate, but it turned out to be not as high as they said it to be. But for chemoradiation, there's only one small series from the Mass General Hospital, included 10 patients with thymic tumors. The response rate was quite high, around 60%, and they had a quite high complete resection rate. But then there's nothing afterwards. So we have done a stage 2 trial, trying the concomitant chemoradiation for locally advanced thymic tumors. And we found the response rate was around 70% after induction chemoradiation. And the resection rate could also be improved. However, for those tumors that still could not be resected after induction, then maybe a tumor debulking is not as good as the definitive chemoradiation after induction. So you really should balance the risk and benefits in such cases.
What are the new additions to diagnostics in thymoma and thymic cancers? Any new type of blood tests, genetic markers which we should look out for?
Unfortunately, there's no, to my knowledge, there's no new modality of diagnosis. I mean, imaging modality of imaging diagnosis. However, as I briefed you in the talk before, I think MRI is extremely helpful, and sometimes it's much better than CT scan in telling a cyst from a cystic thymoma. It's helpful in telling a thymoma from a lymphoma, and it's very helpful in telling whether the tumor has invaded the vascular structures, especially the veins and the great vessels like the innominate veins, the superior vena cava, and aorta or the heart. So I think MRI is a very useful tool, and I would highly recommend that most of the patients suspected having anterior mediastinal with an anterior mediastinal mass suspected of a thymic tumor should receive a MRI in addition to CT scan.
There are so many modalities in surgery now, in MIS surgery, that is.
Yeah.
There's VATS, there's robotic, there's subxiphoid. Do you have any preference? And if so, why?
Well, I think surgeons are usually well ahead of the guidelines. We want to push the boundary forward. So we have been trying minimally invasive surgery for thymic tumors for almost 2 decades, around the world. And there are accumulating evidence that if you observe the oncological principles, minimally invasive surgery can have the similar outcomes comparing to open surgery. Personally, I started to do robot first. And then I turned to VATS, because to me, robots has little additional advantage comparing to VATS. And in terms of VATS, there are different approaches as well. We have lateral approaches, we have subxiphoid approaches. I think it's both of these and all of these are acceptable as long as one observes the surgical and oncological principles. We make it a surgery, we take out tumor completely without violation of the capsule, without spillage of the tumor causing dissemination. And which one to choose would depend on your experience with a specific procedure approach, and also with the learning curve. With the learning curve, you can basically do anything.
I went the other way. I used to do VATS. I moved to robotic because I find it more convenient. But
okay, great.
But I think the message is that you have to, as you said, maintain the principles of oncology and make sure that the whole idea, it's not a cosmetic operation, so you need to get the lesion out intact and in full.
Exactly.
So we have just two more questions. Currently, is there any clinical trial where we, as the people in ASEAN, we can send our patients to? And is there any new trial whose results you're, as a member of the ITMIG committee, you're awaiting eagerly to say as it will change direction?
Well, definitely. The ITMIG has been trying to organize a phase 3 prospective randomized trial comparing radiation or follow-up after complete resection of thymic tumors. We have been working on this for more than 8 years, but unfortunately, it's really difficult to accrue enough patients for such a rare and indolent disease. So currently in China, we have just started a phase 3 trial with a similar design. We would only include patients with a higher risk of recurrence, as I just said in my talk. That means all thymic carcinomas or neuroendocrine tumors, or locally invasive type B, B2 and B3 thymomas. These are the high-risk patients. We are trying to, compare whether post-operative radiation is indeed helpful in these patients. So if any of you are interested in joining us, you're more than welcome to contact me, and I will send you the study protocol and how to let you know how to join force on this trial. I think for a rare indolent disease, as I mentioned, more hands is definitely necessary to build a higher flame. We would definitely welcome all of those who are interested in this disease to join us on this trial.
Last question. How long do you follow up a case of thymoma?
Oh, very long. Usually, yeah, for thymomas, after complete resection, as I said, I would follow the patient for 10 years. Yeah, for thymic carcinoma, at least 5 to 6 years.
Dr. Detterbeck had an interesting answer. He said, I will follow it up for life.
I don't know.
Yeah, I also don't know, because the rationale, the argument was the stage 1s usually recur after 10 years. The stage 2s and 3s recur after somewhere between 3 to 5 years. So we don't know where we are in the cycle of follow-up. So that is I don't know. I would say, as long as the patient still is interested in seeing my face, I will follow up.
Yeah, you're right. If you only consider the risk of recurrence, I think the patient should be followed lifetime. But you also need to consider the radiation exposure, medical expense in general, and also the patient's, psychological burdens, their quality of life. So there are a lot of things to balance, risk and benefits again.
Professor Fang, it's been a great pleasure conversing with you. Now I'm going to let it to Dr. Soon to carry on.
Thank you. The pleasure's mine.
Excellent talk, Prof. Fang, and very good Q&A session with Prof. Anis as well. In the interest of time, I'll quickly run through the questions that have been posted to you on our Q&A site. From Dr. Pandungkiat from Thailand, he was asking, which lymph node stations do you recommend for harvesting?
Yeah, that's an important question. Actually, when we put forward the first TMS station by the ITMIG and UICC, we also put forward a nodal map for thymic tumors. That was published in the Journal of Thoracic Oncology in 2014. In that nodal map, we divided the lymph node into two regions, the anterior mediastinal region and the deep mediastinal region. The deep mediastinal region would be lateral to the bilateral phrenic nerves. That will include the station 2 and 4 on the right side and 5 on the left side. That will also include subcranial nodes, the hilar nodes, as well as the supraclavicular lymph nodes in the neck. So according to the prospective observational study in China, we found that for low-risk patients, the lymph node metastasis would be mostly in the anterior mediastinum. That would be N1 nodes according to ITMIG nodal map. So if you're doing a total thymectomy, you would theoretically you have already removed all the lymph nodes together with the thymus. So it's not necessary to do any additional dissection beyond the phrenic nerves. So the only thing you need to do is to take the lymph node out and send it to your pathologist. And but for high-risk tumors, and especially neuroendocrine tumors, lymph node involvement would be quite extensive. Usually there are N2 involvements in these patients. So for such high-risk patients, I think dissection of the deep mediastinum is important. So again, it's stratified according to the risk of involvement.
From Prof. Punarek, he was asking, in real life, what sort of cases do you ask for neoadjuvant therapy? And what percentage of total malignant thymoma would your thymic carcinoma would you ask for neoadjuvant therapy?
Well, if you're talking about neoadjuvant, you mean that you're still going to do a surgery, right? So
yeah, I think that's what you meant. Probably trying to shrink down the size a little bit.
Yes. So the intention would be to downstate the tumor and to improve the resection, the chance of resection in such cases, right? Yep. So usually when the tumor is potentially resectable or it's not resectable upon first presentation, we would consider neoadjuvant therapies. And also for those high-risk tumors, which tend to have a distant metastasis or lymph node involvement, like neuroendocrine tumors, like carcinomas. Most of these tumors would would be already in locally advanced stage upon presentation. We would do we would try a neoadjuvant therapies. But for those well demarcated, well encapsulated lesions, well, although the tumor may be large in size, it's not difficult to take them out completely. So it's really not necessary to do neoadjuvant therapy in such a situation.
So it depends on whether, on the radiological features, whether it's borderline resectable or not.
Yeah, exactly. I think the current evidence is like that, yes.
Okay. Dr. Ing Xiang from Singapore is asking you, what is your input on risk of tumor seeding when opening the contralateral pleura to complete a thymectomy, especially in high-grade tumors with pericardial involvement?
Well, I think it's very critically important to avoid, tumor seeding, no matter which side it is, on the ipsilateral side or on the contralateral side. But if there's a risk of tumor seeding, I think at least I would avoid opening the contralateral pleura to avoid the seeding on the other side. Because if the seeding was limited to one side, we still can deal with it with a pleurectomy or plus with or without irradiation. But if there's seeding on bilateral side, it's really difficult to deal with.
So when you do a total thymectomy, do you not routinely open both pleura to get down to the side?
I usually would I would make the decision according to the extension of the disease. If it's a well encapsulated tumor, I would do a total thymectomy without a deliberate intention to open up the pleura on the contralateral side. But if it's a locally invasive disease, I would try to stick to one side if possible.
Okay.
I would tend to agree with that, because also technically it becomes easier if you keep the pleura on the other side intact. With gas insufflation, you'll get more space. So it helps for a while, technically at least.
Yeah, technically, yes. I agree.
So let me ask you a question. Why do you choose 3 centimeter for your cutoff for your small nodule? Why not depend on radiological features? Because some thymic cysts can be very big.
Well, 3 centimeter is not my
yeah. Why do the guidelines?
Well, it's because if you look at the lung cancer screening trials, most of them use 3 centimeter as a cutoff value to decide whether it's a small or a big lesion. And also, we did a survey at the WCLC meeting 2 years ago to the audience when we are having this special session on anterior mediastinal incidentally detected anterior mediastinal lesions, and most audience agree with 3 centimeter as a cutoff line. So that's why I use it. Yeah, it's more intuitive, I think.
Yeah, so I'm just informing the audience about the 3 cm is just an arbitrary figure, isn't it? So sometimes it's it's more dependent, or it's more important to depend on the radiological features when you take a look at a patient, isn't it? So Anis was mentioning what sort of patient would you not operate on? Would you operate on a patient, let's say, 80-year-old patient with an incidental finding of a 2 cm anterior mediastinal mass?
That's a good question. Actually, you saw I have 13 patients suspected of having small thymomas that was incidentally detected, and most of them are still on follow-up without surgery. That's because we think the tumor are most probably low-grade tumors with a well demarcated without lobulation. It's still small in size, and the tumor doubling time could be as long as 2 years or 3 years. And if the life expectancy of this patient is not that long, especially those geriatric patients with a lot of comorbidities, I really don't think surgery is definitely necessary. But you can put the patient on follow-up. Yeah.
But I think the decision should be ultimately left to the patient, I suppose.
Yes, of course. And also, it depends on what kind of procedure you're trying to do.
Yeah.
Because if you just do a VATS, Thymectomy for a small lesion, it's quite simple and straightforward, and it carries very low, morbidity associated with the procedure. So for a healthy geriatric with a small early stage lesion, it's okay to take it out. Yeah, but like Anis put it, the decision is in the patient's hand. Yeah.
Yeah. The informed consent process, isn't it? Giving them the information to make the decision. So
yes.
Rob Punarek also has another question. They say, how many redos have you, or third or fourth operation do you do for recurrence? Have you done like for recurrence? How aggressively do you pursue recurrence? Once, twice,
Amazingly, we are doing more and more redo operations nowadays. Most of the patients are from referred to us from other centers. Usually, they would have already received the first or second operation like 10 years ago or 5 years ago at another institution. Then they develop recurrence, either local or in a pleural cavity or both. So if the patient is in good condition and if the recurrent lesions could be resected completely, then we would go for it. So I would do a redo operation almost, I would do 1 or 2 cases almost every week.
Wow. Okay. I think in the audience, I think Prof. Agas is listening. He has patients whom he has done like 5th or 6th time. And I think the most valid reason actually comes from the neurologist, because many of these patients have thymoma with myasthenia, and then the neurologists come to you and say, hey, I'm not going to get a handle on this myasthenia. Please go and resect it for me out. And with great reluctance, we are there at it again, removing it. So,
yeah, sometimes this really helps.
Yeah.
I think, what is the role for debulking in thymectomy in thymic carcinoma with vascular or vital structure encasement by an anonymous attendee out there? So any role for debulking in advanced stage thymic carcinoma? With
I would usually avoid debulking in any thymic tumors. I would try my best to remove anything that could be removed, including the veins, but definitely not the heart. You can take the lung, you can take the phrenic nerve, as long as it's unilateral. I really don't think debulking is a good surgery. But if you are already in there and you find that the tumor could not be completely removed, then I think you won't just leave the tumor there and back out. So you would try your best to remove as much as you can and hope that radiation would be helpful after surgery. I think that's the second choice.
Last question. So do you believe in the role of cryotherapy for malignant thymoma from Dr. Roland from Indonesia?
Unfortunately, I have never tried cryotherapy for thymic tumors. I would be curious to learn whether if anyone has tried it and whether it's indeed more effective than like radiation or chemotherapy. I would be curious to learn anything new in this field. Is
Yeah,
there anyone?
Sorry.
Yes.
I thought the biggest experience for cryo was from China.
Really?
It used to be.
Surprised.
It used to be in the 90s, definitely, because they had a project for liver, which they transferred to the Mediastinal, I remember. But after that, it went out of fashion, I thought. So
Yeah, yeah. I think that's a good answer, because why it went out of fashion? So simply because it's not that effective as one thought. Yes. Yeah.
I think we have an amazing session from Prof. Fang and Prof. Anis. It's been I've benefited greatly from the knowledge that is gained, and a lot of the participants are still with us, even though we're a little bit overrun on the timing side. And I believe the reason why Prof. Fang don't use the robot is because he operates better than a robot. So you should visit him.
no, you're not. He operates with a lot of robots.
And he doesn't use the robot because,
human, yeah.
I'm sure Prof. Fang would love to host you guys when you visit him. So if you are interested, please contact either him directly or contact us through Seeds, and we'll love to set up attachment with you for
Definitely.
you with Prof. Fang.
Yeah, definitely. Thank you.
You should visit him. It's an amazing hospital. So thank you very much, everyone. Thank you for your participation. We'll see you again next week. The topic is on Thymectomy.
Thank you, Prof. Fang. Thank you, Dr. Soon. Wonderful.
Thank you. It's a real pleasure to talk to you. Thank you.